utility of rapid syndromic testing for meningitis encephalitis in children and adolescents. I would like to introduce our speaker, Dr. Jaime Fergie. He is Director of Pediatric Infectious Diseases and Hospital Epidemiologist at Driscoll Children's Hospital. He has an appointment as Professor of Pediatrics at Texas A&M University College of Medicine. He's Clinical Professor of Pediatrics at University of Texas Medical Branch at Galveston, and he is Adjunct Clinical Professor at the University of North Texas Health Science Center at Fort Worth. Dr. Fergie is board certified in pediatrics and pediatric infectious diseases and is a fellow of the Infectious Disease Society of America, the American Academy of Pediatrics, and the Society for Healthcare Epidemiology of America. In addition to being a member of the Society for Pediatric Research and the Pediatric Infectious Diseases Society. Now, I would like to hand the mic and presentation to Dr. Fergie.
All right, well, good morning to all of you. It is indeed a great pleasure for me to be able to speak to you from the city of Corpus Christi in the state of Texas in the United States. For me, it's 9 p.m. on Wednesday, and I know that for all of you, it's Thursday. So I am delighted to see that we have a very wide audience. And I have had the pleasure of lecturing before live recently, actually, in South Korea and in Japan and in the Philippines and Singapore. I haven't had the pleasure yet of visiting India, Indonesia, Australia, or New Zealand, but I do sincerely hope to be able to lecture there in person and have the opportunity to interact with all of you. So the subject today, I think it's of great interest for all of us who take care of children and adolescents. First of all, if you heard in my introduction, I'm an infectious diseases specialist and, of course, a pediatrician. And I have been dealing with these problems of infections in the central nervous system for many years. I have been here in Texas now for 25 years at this same children's hospital. And some of the most challenging cases that we all face all over the world, doesn't matter in which country you are infections of the central nervous system. Because of the sequela, because of the significance this has for the life of the child, for the possibility of mortality and long-term disability. So that's what I'm going to talk to you about today. I'm going to talk about diagnostics. I'm going to talk about how the implementation of the multiplex PCR testing that we use at Driscoll Children's Hospital and that's been used all over the world has really changed the way in which I manage these patients, the approach, and the great satisfaction that I get from being able to very quickly and accurately diagnose the cause of meningitis and or meningoencephalitis. So this is my hospital you're seeing here on the screen. It's Driscoll Children's Hospital in South Texas. Give you an idea where I am located. I am located relatively very close to the border with Mexico, because the lower part of the border of Texas, of course, is the border with with Mexico. So we are actually a hospital that receives patients not only from the United States, from Texas, we also receive patients from Mexico. It's a large extension of land, many counties, and we serve about 2 million people in this area. And we have satellite centers in cities that are located close to the border with Mexico. You know, like to begin the presentation with this article that appeared in the New England Journal of Medicine in 2012. Actually, it's very interesting because this was one article was published in the special edition for the 200th anniversary of the New England Journal of Medicine. And when I was reviewing the presentation today, I realized this is so appropriate, this is so timely. Even though I'm not going to talk about the new coronavirus 2019, the title of this article is very appropriate because it deals with the perpetual challenges of infectious diseases. And it is, as you can see, there's potential for unpredictable and explosive global impact, frequent acquisition by hosts of durable immunity against reinfection after recovery, reliance of disease on a single agent without requiring for cofactors. Transmissibility, of course, is something that makes infectious diseases so extremely concerning. And that's the reason everybody now in the world, in your part of the world in particular, is so worried about the coronavirus. The potential for eradication is also another characteristic of infectious diseases. And again, there's a long list. But when you look on the other side of the slide, you see the leading causes of death from infectious diseases. And interesting, meningitis is there with approximately 300,000 deaths a year. Of course, number one are respiratory infection, then diarrheal diseases, HIV/AIDS, tuberculosis, malaria, and then meningitis. But it is a significant cause of death in the world. So very appropriate when you think about what we're seeing right now around the world, how indeed infectious diseases present a perpetual challenge. Well, let me say that it's incredible how things have changed in the world in terms of the diagnosis of infection. And I like to put this slide here of Antoine van de Leeuwenhoek, the Dutch microscopist who was the first to observe bacteria and protozoa using this very primitive microscope. And it's hard for us to imagine how was he able to see anything by putting a drop of fluid here and then looking through it through a glass, they could see the organism. But this was, of course, completely revolutionary, and it was able to do away with the idea of a spontaneous generation that existed before. People were able to see microorganisms. So things have really moved forward in the diagnosis in microbiology. So from the Infectious Diseases Society of America, there's this publication that I like that came out in 2013 with the title, Better Tests, Better Care, Improved Diagnostic for Infectious Diseases. And what you see here is the different diagnostic methods, going back to microscopy, the use of gram stain, and you know how fast they are. But then when you get into culture, of course, you know, cultures, depending on what you're culturing, obviously, from bacteria from 1 to 2 days, 3 days, to cultures from mycobacteria or fungus, and that can take, of course, much longer. Then we deal with antimicrobial susceptibility. It takes some time, although now it's mostly automated. Then acute and convalescent antibody titers for the diagnosis of infectious diseases. But that, unfortunately, antibody detection takes a long time. Then, of course, you have monoclonal antibodies that are faster, antigen detection that are done quickly but are in general very insensitive. And then you have what I'm going to be talking to you about today, the real-time polymerase chain reaction, in particular the multiplex PCRs that give you answers in a relatively very short period of time. And of course, one of the most modern things we have now is the mass spectrometry in the microbiology laboratory that can identify an organism in a matter of minutes. So all of this brings me to the question of what is the role of diagnostic tests? Well, of course, we use diagnostic tests all the time in medicine to detect the specific pathogens, to discover new pathogens, to help us guide therapy, to help us gauge response to therapy, assess prognosis, and of course, we use diagnostic test for disease surveillance. We do it all the time. When you look at influenza testing and we have an idea of the epidemic, are we beginning the epidemic? Is it flu A? Is it flu B? And then when did it reach its peak? And then when it goes down? That's disease surveillance too. So when you look at all of the elements that you have in the laboratory, the field of clinical microbiology is in transition. And the standard of care that we utilize and that you utilize is now a combination, a hybrid of old technology and new technology. When I go to my microbiology laboratory, I still see and I still order gram stains. And on the other hand, in the laboratory, I have my multiplex PCR, my film arrays equipment that give me immediate results, an hour result for very important patients. So with automation and highly multiplex assays, individual pathogens can be easily identified in a wide variety of specimen types, including blood, urine, tissue, mucosal swabs, spinal fluid, respiratory secretion, and stool sample, between others. So what are the characteristics then of an ideal diagnostic test? Because I'm going to be talking about the film array PCR for spinal fluid in particular moment. So what are in general, what are the characteristics of any diagnostic test that make them ideal? Well, first of all, you want to have a test that is accurate, because it doesn't matter how fast the test is or how easy it is to perform the test if the test is not accurate. So an accuracy, of course, relates to sensitivity and specificity. You want to have the high sensitivity and high specificity, but you know that for most tests, when you go very high in sensitivity, the specificity goes down, or vice versa. You have high specificity and low sensitivity, relatively speaking. But when we deal now with the multiplex PCR test, and one of the wonderful things about this is that they actually have high sensitivity and high specificity at the same time. So there are other characteristics that are very important for all of you. And for those of you who work in the laboratory, this is important. You want to have tests and equipment with extended shelf life. So if you buy them, you can have them for a long time without being concerned about the reagents expiring, for example. You want equipment that is portable, that you can move from one place in the laboratory to another place in the laboratory that is not too bulky, that is easy to handle. Very important point, the next one. Minimal technical skill for operating. So the easier a test and equipment is to operate, the better it's going to be, the more practical it is going to be for your laboratory and for your people. Speed is critical when you're talking about infections of the central nervous system, either to confirm or to rule out the presence of an infection. Another point that this multiplex PCR, this film array CSF PCR has, and all of the film array panels do, is the on-demand testing capability, minimal batch size, because you know how frustrating it is if you order a test and the laboratory cannot run it because they need several samples to come together to open a pouch and then not waste material. Sometimes the kids come for 5 samples or 10 samples, but the kits for the film array is just 1 sample for patients. You don't have to wait. The laboratory doesn't have to wait for more samples to come in order to run this CSF. Low cost, of course, is nice if you have it. And another important point for the laboratory people, for the administrators, is that the equipment be suitable for a broad range of clinical samples. And that is actually the case with the multiplex from film array. So when we deal with CNS infections, or CNS, let me call it this way, CNS inflammation, and the inflammation of meningitis, meningoencephalitis is not always caused by infection. Of course, the most concerning one for us is infection, but it can be a post-infectious inflammation, or the inflammation in the meninges or the brain may be caused by non-infectious agents. And then, of course, we have the problem when we do culture, the culture methods are slow. And a very real problem that I deal with all the time when I'm trying to diagnose meningitis in particular is the interference with prior antibiotic use, because many of the children and adolescents that come to me with symptoms and signs of meningitis They already were seen by another doctor a day or 2 days before or 3 days before and were receiving antibiotics, and that interferes, of course, with the result of the culture. Very well. A related subject, now that I got into the spinal fluid, I got into the meningitis encephalitis, and this is an article from the Lancet Neurology from November 2017. It's a extremely large paper because they look at the global, regional, and national burden of neurological disorder from 1990 to 2015. So you go to this article, it goes country by country. And I want you to look at this slide here, the graphic, and you see it refers to what they call the disability adjusted life year. And that includes death, and that includes years or time in which the people were disabled because of an underlying neurological disease. When you look at the first column, those are individuals between 0 and 5 years of age. And the largest part of this column in gray of the disability adjusted life years are those related to meningitis, followed by the next part of the column, followed by encephalitis, and then tetanus. But very, very striking. Now, the meningitis burden of disease, as you can see, goes relatively lower later on, but it never goes away. It never goes away. Of course, other important things appear later on in life. You know, you have the epilepsy, you have the Parkinson's disease, the Alzheimer's disease, but meningoencephalitis is always a problem, it's always a burden throughout the life of the people, very significant for those of us who deal with children. Because, of course, if you have a child who gets with meningitis or encephalitis severe, then the sequela can last for a lifetime. So what's the problem we have from a clinical point of view? Well, there's an overlap in the clinical presentation of many central nervous system infections and inflammation. Therefore, it is not possible to reliably predict the pathogen based on clinical signs and symptoms. It's not possible to do that. And by the way, this problem, we have it not only for infection of the central nervous system. That's the same problem we have when we deal, for example, with a respiratory infection, with an upper respiratory infection, lower respiratory tract infection. They have similar symptoms, many different pathogens causing the same fever, cough, runny nose, respiratory distress. Or with the gastrointestinal infection, we have the same symptoms, the abdominal pain, the fever, and the diarrhea. So very important in inflammation of central nervous system for meningitis and meningoencephalitis. Many different pathogens, viral, bacterial, protozoan, can give you similar symptoms. For example, traditional symptoms of meningitis: headache, fever, meningismus, Kernig, Brzezinski sign, the ultrasensorium, all of those things are present. Now, the younger the patient is, and you know this, I'm sure, those of you who deal with children, the infant, well, they cannot tell you they have headache, so you have to rely on the fact that the baby appears to be irritable, fussy, and then it's very difficult in a little baby to find any meningeal signs. So it's more difficult the younger you are to make a specific diagnosis because all of these traditional findings may not be present. This is an article I like too from the Emergency Medicine Clinic of North America because it has this algorithm. So you have meningitis at the top that can be bacterial or aseptic, meaning non-bacterial. But aseptic is not necessarily viral. Aseptic can be several things. Aseptic can be non-infectious, and from the non-infectious can be meningitis caused by drugs, or it can be caused by systemic diseases, or it can be caused by cancer. So sometimes leukemia can present as meningitis. So on the other side of the aseptic, you have the non-bacterial infections. Viral, of course, being the most important one. But keep in mind, they're also non-viral that also give you similar symptoms and signs as the viral infection, the partially treated bacterial meningitis, the meningeal inflammation caused by a parameningeal foci of infection, the atypical and the non-pathogenic bacteria, tuberculosis, syphilis, Lyme disease, fungal, many other ones. So it's a complex. This is a diagnostic dilemma many times with great consequence. So what about now encephalitis? And I want to make a point. Many times it's not a completely separate entity, meningitis encephalitis. Many times you have this meningoencephalitis presentation. But traditionally, encephalitis is defined by the presence of an inflammatory process of the brain associated with clinical evidence of neurological dysfunction. All the pathogens reported to cause encephalitis, the majority are viruses. Now, this is very frustrating to all of us, that despite extensive testing, the etiology of encephalitis remain unknown in many patients. I would say now, in the year 2020, I would say the majority we can diagnose, but there is probably at least 40-45% in which we cannot diagnose. And that really is always a frustrating problem for all of us. So another challenge is that for many patients with encephalitis, we need to try to determine the relevance of an infectious agent that has been identified outside the central nervous system. And then also important to distinguish, and this is a challenge for many of us, is to distinguish between infectious and post-infectious encephalitis, such as acute disseminated encephalomyelitis, and from non-infectious diseases, as I was discussing with you before. In this paper, this is actually a guideline that is published in Clinical Infectious Diseases, and that anybody can download for free because it's in the Infectious Diseases Society of America website. It's called the Management of Encephalitis Clinical Practice Guideline. They emphasize that an attempt should always be made to establish an etiologic diagnosis. I mean, that makes sense. We always want to make the etiological diagnosis, but they emphasize that point. An interesting article that I like also from the Lancet Infection is this one. It came out in September 2018 from the United Kingdom, from the National Health Service, on the incidence, etiology, and sequelae of viral meningitis in the UK in adults. It was a multi-center prospective observation study, but it makes a very important point. You know, they had 1,126 patients that clinically they thought the patient had meningitis to the point in which they did a spinal tap. And 57% actually had meningitis. But it means that there were many there that had 43% that had no meningitis, despite having clinical signs and symptoms that make the physician concerned. Now, from those who had meningitis, 231 had viral meningitis. And what I want to highlight to you is that these viruses can be detected using the film array PCR. Almost all of them, not EBV, not measles or mumps, but the most important one, enteroviruses, HSV2, varicella zoster virus, HSV1, CMV, all of those and more can be detected with the viral panel for spinal fluid from film array, the meningoencephalitis panel. Then they detected 99 patients with bacterial meningitis. Of course, the most common one was Streptococcus pneumoniae, followed by Neisseria meningitis, so Haemophilus influenza, Listeria, Streptococcus pyogenes. There's just one, very uncommon. And actually, they also had 4 patients with Cryptococcus neoformans, and that is something that is remarkable. That's something that is included in the meningoencephalitis panel from bioMérieux. There have been many publications dealing with the implementation of the meningoencephalitis panel. Here, just as an example, from September 2016, Journal of Clinical Microbiology, a multi-center evaluation of the BioFire film array meningoencephalitis panel. I mean, that's the one from bioMérieux, for detection of bacteria, viruses, and yeast in CSF specimen. And what you see here on this slide are all the bacteria and viruses and yeast, of course, that were detected in these multiple places, and also the differences by age. For example, CMV was detected in those younger than 4 months of age, and there was 1 to 17 and 1 18 to 34. The enterovirus, for example, the most common one, the majority very young baby, but throughout all of this life until 18 to 34, they detected some. So there have been many of these studies that in which they evaluate the use of the BioFire or bioMérieux film array PCR. Here is one that is, again, throughout the United States. This study is multi-center evaluation. The first author of this study is from a hospital called Nationwide. This hospital is in Ohio, Columbus, Ohio. And the figure 1 on the publication, I think, highlights something important, because in blue are the results that were concordant, in which the traditional testing and the multiplex PCR testing were concordant. But perhaps to me, the most important one are the ones in red, discordant film array positive, in which the traditional method was negative. And you can see, for example, if you look at this Streptococcus pneumonia, 7 more cases diagnosed over the traditional method. Human herpes virus 6, 3 more over the traditional PCR testing. But I will challenge you something. Most people do not send CSF to be tested for human herpes virus 6 separate. It's very unpractical to do that. Now, the amazing advantage of having a multiplex panel is that you can send one sample to be tested for all of these, for a multitude of pathogens. You don't have to order separate testing because there's all present there in the panel. So what's the story with us at my institution? When I learned about these panels, I really wanted to be one of the first adopters of the panel. So actually, my institution was one of the very first institutions in the United States to incorporate the use of the multiplex PCR panels in the clinical laboratory, not in the research laboratory, but in the clinical laboratory. We began in the year 2011 using the multiplex PCR panel from bioMérieux for the respiratory secretion. We do about almost 4,000 a year of those tests. Then the year 2014, we adopted the gastrointestinal panel. We do about 1,100 of those tests a year. And now, in relation to this presentation tonight, I can tell you that it was December 2015. As soon as it was available in the United States, we began to implement the meningoencephalitis panel here at my institution. Yeah, we do about 250 a year. Then recently, we also added a pneumonia panel. But going back to the meningoencephalitis panel, what I would like to highlight to you is this. Every spinal fluid is done in my institution. For somebody with concern for infection, of course, or meningitis, is going to have this test done. Who doesn't have it done? Well, somebody who is going to have a routine neurosurgical procedure, or the children who receive intrathecal chemotherapy. Well, it's not done for them. But everybody else gets this panel. And the panel includes the following. Include E. coli, Haemophilus influenza, Listeria, Neisseria, Streptococcus agalactiae, or GVS, or Group B, Streptococcus pneumonia, CMV, enterovirus, HSV1, HSV2, human herpesvirus 6, human parechovirus, varicella zoster virus, and from the yeast, Cryptococcus neoformans or Cryptococcus gatti. It cannot differentiate between those two. And what is in red here on this slide that I think is important? In red is organisms, viruses that we couldn't before diagnose in the United States. Or there were no other similar tests available in the United States by the time this test was diagnosed. And look at this, the overall sensitivity is 94.2% with an overall specificity that is 99.8%. So a couple of examples, couple of clinical examples of patients I've seen here at Driscoll at my institution. 8-day-old female neonate. The mother was 28 years old, third pregnancy. She received prenatal care. Her group B streptococcus colonization status was positive. The mother had a normal delivery, and the patient was discharged home on the second day of life. Day 6 of life, the patient was hospitalized again because of fever. Temperature was actually 39.1 Celsius. Patient had conjunctivitis of the left eye. And here you have the white blood cell count that was relatively unremarkable, although there was substantial left shift with 1% metamyelocytes and 14% bands, with a normal hemoglobin and platelet count. What I want to highlight here, and would like you to see this, is that, of course, this neonate had spinal fluid obtained, and it had white cells of 6, red cells of 2, protein of 89, and glucose of 44. That is a completely normal spinal fluid. I think that's very interesting right there. We did the blood, CSF, and urine culture, the bacterial culture were all negative. But we also took that sample of fluid, the CSF, that appeared completely normal, and we sent it for our meningoencephalitis panel, the one that we're talking about today. And the meningoencephalitis PCR panel immediately came back positive within a little bit more than an hour. We already knew this patient had HSV1 meningoencephalitis. Later on, we sent out, and this took a few days to come back, but we got it back, that the PCR in blood was also positive. We did a brain MRI. The patient had encephalomalacia in the left frontal area. The day after admission, patient developed multiple cluster of vesicles, but it was after the admission that it would have been easy to diagnose. And the vesicle had HSV1 too. So this patient was treated with acyclovir for 21 days, and at the end of the 21 days, they will repeat the spinal tap in order to be confident we could stop therapy, and repeated the meningoencephalitis panel PCR, and now it was negative. Another recent case, a 12-year-old adolescent male who was hospitalized at my institution with a complex congenital heart disease that included dextrocardia, transposition of the right ventricle. This patient had required multiple cardiac surgeries because of the complexity of his condition, that in between other interventions had pulmonary artery binding, he had a Glenn procedure, enlargement of the atrial septal defect, and pulmonary angioplasty. This patient unfortunately developed a complication that some of you are familiar with in this congenital heart disease, and that is a protein-losing enteropathy that led to hypogammaglobulinemia and the development of multiple papillomas on the dorsum of the hands, and on the face and on the fingers. So, the patient was admitted 2019, June 24. On June 27, underwent a Fontaine fenestration. On July the 3rd, complained of headache. On July the 4th, severe headache with multiple episodes of vomiting and fever. On July the 5th, headache, severe vomiting and fever. Blood culture was obtained. And the problem was that we wanted to do a spinal tap on this patient. We wanted to do a spinal tap. We thought maybe he has a bacterial meningitis, some sense of complication. And we had to wait because the patient was anticoagulated. So it was on heparin. So we had to wait a few days. Now, I would have never imagined the result, but we did it on July the 8th. It had clearly meningitis with 110 cells, with 59% neutrophils, with a glucose of 43 and protein of 45, and a very high opening pressure. And it was extraordinary for me that in an hour, I knew this patient actually had cryptococcal meningitis. I would not have suspected that clinically. I thought it was going to be a bacteria, and the patient was receiving empiric therapy for bacteria, but not for fungus. So the culture later on became positive. Patient was hypogammaglobulinemic. We were able to treat immediately with amphotericin B and flucytosine. Then that was followed by fluconazole. We had to put a lumbar drain because this complication of cryptococcal meningitis, as you know, it's a increase intracranial pressure, and the patient did eventually improve and did well, and still receiving fluconazole. So I did a study at Driscoll of the implementation of the meningoencephalitis panel from December 2015 through March 2018. We did about 576 samples during that period that we included. We had 103 positive results. We had to exclude some of them that were repeated testing. But here you have on this graphic from my study the total of PCR tests ordered and the total number of positive in red. And you can see we do it throughout the year. Throughout the year, it's always available. The other wonderful thing for us at my institution is the test is available 24 hours a day, 7 days a week. We always have people in the laboratory that can run the test. And one of the advantages of the test, as I mentioned to you before, an ideal characteristic of a test is that you don't need anybody who is highly knowledgeable. You don't need a PhD level individual to do it because it's very simple to run. So these are the 99 positive we had. You see the age groups from neonates to adolescents are represented there. The majority were infants, a predominance of males over females. And when you look at the seasonality, of course, it's not surprising that there are more cases in the summer month because that's where the enteroviral season. But for me, it was very exciting to have the test available because I knew that some of the cases that looked like enterovirus, but the enteroviral test came back negative, were parechoviruses. And here we were able to diagnose, you can see in red, several cases of parechovirus throughout the study. And also, very significant, something we were never able to diagnose before in an easy way was the human herpes virus 6. And as you can see in green, there were several cases of human herpes virus 6 during the study. Here are the areas of the hospital where a patient came from the intensive care unit, the inpatient area, observation area, neonatal area. And what I like to highlight to you, emergency department. I think this test is extremely valuable in emergency department because it will allow you to diagnose a meningitis, of course, with spinal tap, and then if you find out that it's like here, enterovirus or human herpes virus 6, then you're really not going to do any intervention. If the patient is clinically doing well, you can then say you can go home with symptomatic therapy, with medication for the pain, as long as the patient is stable. But then you don't have to do anything else. You don't even have to admit the patient to the hospital. You will notice, of course, I'm sure it happens in many of your institutions, that this patient, when they come in with meningitis, you're going to put them on bacterial treatment. You're going to put them on antibiotics until of course, you can feel confident that the diagnosis. So one of the things we did in the study is that we realized that people, once they knew, we could tell the doctor there's an enterovirus, is a CMV, is human herpes virus 6, then the antibiotics could be discontinued, the human simplex virus 1 or 2. So this is an important part of the study. 18 patients with positive meningoencephalitis PCR panel were pre-treated with antibiotics as outpatient in our emergency room. 30 had viruses, including 9 enterovirus and 4 human herpes virus 6. So if you think about this, without this PCR test, you would have thought, well, child received antibiotic before we did spinal tap. Maybe the culture is negative because we give antibiotic and you feel obligated. You feel forced to give 10 days or 14 days of antibiotic because of the possibility of what it's called a partially treated bacterial meningitis. But if you do the test now, hey, actually it's an enterovirus or human herpes virus 6, you can discharge them. So that I think to me has been an extremely valuable use of the meningoencephalitis panel PCR. And none of the patients with viral meningoencephalitis had positive blood, CSF, or urine culture. We had the culture, but they were all negative. Of the 7 meningoencephalitis PCR positive bacterial meningitis, 4 had positive CSF cultures, 5 were pretreated with antibiotics. However, we had 2 true pretreated bacterial meningitis. So this one had negative CSF cultures. Negative CSF culture because indeed the patient received antibiotics. And these tests then allow us to make the diagnosis of bacterial meningitis in somebody with a negative culture, and knowing then that we really have to complete therapy for, in this case, Streptococcus pneumonia. Conclusion from the study was the introduction of the test made it possible to detect human herpes virus 6 and pericoviral meningoencephalitis, shortened the length of hospital stay from institution. Physicians, of course, felt better, more comfortable in discharging all their children before the culture were resolved. And I think professionally, you feel better. And the families actually like to know specifically what's the name of the pathogen, what's the name of the virus that is causing the illness of their children. And we feel, of course, a positive CSF meningoencephalitis panel from film array bioMérieux PCR is reliable enough to discontinue antibiotic and to plan discharge before cultures are ready. And in the era of antibiotic stewardship, it's really important to be able to stop unnecessary use of antibiotics. Now, these tests have been used throughout the world. And if you look at the literature, there's so many articles from all over the world. This one is relatively recent. This is from 2019 from Brazil, from Sao Paulo. And it's on the use of the meningoencephalitis panel. And they these were private hospitals in Sao Paulo, 436 samples. They had 25 positive bacteria. They had 174 positive virus and 1 Cryptococcus neoformans. They were able to diagnose using the same panel that we're talking about today. And I thought it was really interesting to highlight this. This table includes individuals who were positive only by the meningoencephalitis panel, but they were negative by culture. And so you can see here the very large number of cases of strep pneumonia, Neisseria meningitis, Listeria monocytogenes 1, Haemophilus influenza. A study published in the Pediatric Infectious Diseases Journal in 2018 that comes from Australia, from the Royal Darwin Hospital, shows the value of their adoption. This is a before and after study, before they had the meningoencephalitis panel and after, and that what they were able to do was to, of course, shorten the time to diagnosis, decrease the antibiotic duration, and decrease the length of stay. All of those are important things from a clinical point of view, and very important for the people who look at the cost of the test versus the cost of the hospitalizations. Another study, it's a retrospective study in infants only, 1 to 60, with residual CSF fluid using the meningoencephalitis PCR and the number of pathogens that they were able to diagnose. And I think this very, very significant. They were able to diagnose more, of course, much more, 38 more pathogens versus 21 that they were able to diagnose in a conventional manner in those infants. Again, there are many studies like this. This is from Salt Lake City, Utah. This one is from also the United States, the Children's Hospital of Colorado. What I want to highlight from this study, in which they compare traditional methods of diagnosis with the multiplex panel, is over here on the right side, is that the percentage agreement is pretty high, between 96 and 100%. And of course, that you diagnose more with the meningoencephalitis panel. A study from China. As I told you before, this is all over the place. The evaluation of the BioFire film array meningitis encephalitis panel for the detection of bacterial yeast in Chinese children. This article was published in 2019. And basically, it's just to show you that they have same type of result, the number of patients they did, the fact that they detected human herpes virus 6, the human simplex, herpes simplex virus 1, enterovirus CMV, like in the many other studies. This study here from the United Kingdom is interesting to me because what they show is the fact that many of the CSF that were normal, they had no plocytosis, actually many of them turn out to have human herpes virus 6. And I think we're learning a lot about human herpes virus 6 now that we have this test. And we don't have to order separate, because I think before you order something separate, it's inconvenient. You have to order multiple tests. You have to order one test for CMV, one for HSV1, HSV2, one for parechovirus, and then test for the bacterial cause. It's very complicated, and you're going to miss something. With this, of course, you only order one test. So I'm going to conclude now and remind you something that I truly believe. This test has changed the management of our patients with suspected meningitis encephalitis. It has changed the way I practice medicine as an infectious disease physician. Every CSF obtained in my institution for a potential inflammation, for a potential infection, is going to have this panel done. It provides, because we have 24 hours a day, 7 days a week staff in the laboratory, rapid, 1 hour is all it takes, an accurate diagnosis. Allows for appropriate antibiotic or antiviral selection, or allows to remove antibiotics. They are particularly useful in those patients who receive antibiotics prior to having the spinal tap done. And sometimes we get unexpected results, the positive PCR test, in the presence of an apparent normal CSF. And we, of course, have been able to discharge children faster from our institution now that we, since 2015, have adopted this test. Now, with all of this, I want to thank you all very much for taking the time from your busy schedule, from your clinical practice, from your laboratory duties, to listen to me so far away from the state of Texas in the United States through this amazing technology of these webinars. And for me, it's truly an honor to have this opportunity. And with this, I will finish my presentation. I will try to answer your questions.
Mhm. Dr. Fergie, thank you very much for your presentation. It was very interesting to hear how you have implemented our ME panel and how you were able to use these for your patients. So now we will start with our Q&A session. I want to remind all the attendees to submit your questions through the Q&A panel that is on the right of your screen. And Dr. Fergie, if you want, I will read the questions out loud.
Okay.
Okay, so let's start with the first question. Can you please comment on how you decide whether to continue investigating for off-panel organisms or to take a negative ME panel result as a proof that there is no infection?
Yes, important, and that's a very important issue, of course. The easy part is when the panel gives me a positive. That, of course, is the easy part. Second point is, okay, if the panel is negative, I am still doing the cultures. I have not stopped doing the cultures. So that, just to be very clear on this, I do both things. I do the routine bacterial culture and I do the meningoencephalitis panel. So for those gram-negative organisms or gram-positive organism bacteria that are not in the panel, then I will get them in the culture. Then, of course, as clinicians, sometimes, depending on the situation of the patient, depending on the epidemiological situation, and if you, in some of your countries or in South Texas, sometimes we're concerned about tuberculosis, then, of course, then we have to order the specific PCR for tuberculosis and the culture. If we have, the low glucose, the high protein, the lymphocytic predominance, then we do that. So going back to your question, if the PCR gives me a logical, clear-cut positive test, it is an enterovirus, then I stop. I don't have to do anything else. And the culture I know is going to be negative, and I can discharge the patient. Or give me human herpes virus 6, CMV, HSV1, HSV2, varicella zoster virus, or strep pneumonia, GVS, then that is easy. If it is negative, I still have my culture result. And if there is a specific clinical question, tuberculosis, for example, or there is a potential of an immunocompromised child, potential for fungal infection, then of course I'm going to be ordering the other tests too. Thank you.
Okay, thank you very much. Another question is, what is the treatment difference for viral meningitis encephalitis for the different viruses that are present on the panel?
Well, yes, it's very important that, for example, there's different antiviral medications that you're going to use for cytomegalovirus, different from the ones you're going to be using for human herpes simplex virus 1 or 2. And probably you're not going to use any for parechovirus, enterovirus, or human herpes virus 6. So the main issue right now for us is like if it is varicella zoster virus, if it is HSV1, HSV2, they use acyclovir. If it is, enterovirus, nothing. If it is CMV, probably it's going to be ganciclovir.
Okay, thank you. Another question is result interpretation an issue when communicating the results to the treating clinician? If so, for which pathogen?
Well, that we really haven't had a problem with the result interpretation on the meningoencephalitis panel because the results are very straightforward. Usually you have only one positive, and it is easy to inform the clinician that is Streptococcus pneumonia or group B streptococcus or Neisseria meningitis or Haemophilus influenza. There is not a problem that I have encountered with the meningoencephalitis panel for the CSF. Right? So not a problem there. The results are very clear, and the laboratory and the clinicians interact very well from that point of view.
Okay, thank you. We have another question from India. They want you to share your experience with detecting bacterial meningitis by the BioFire ME panel in patients that were already started on antibiotics.
Yes, thank you. And that's what I was showing you on one of my slides. And that is that it's extremely useful both ways. One is, the first thing is, okay, you and I get many patients, you in India, here in Texas, many patients who come to us who already receive an antibiotic by a doctor. And now you may have the situation that you do a spinal tap, it looks like a meningitis, nothing grows on the culture. And then you think, well, we have to treat for bacteria. But what I was showing you in one of the slides was that many of them, we had about 9 or 10 that were negative bacterial culture. Patient received antibiotic, but we were able to detect enterovirus or human herpes virus 6. So with that information, then we were able to stop the use of antibiotics. Also, I show you 2 cases in which the culture was negative, the patient received antibiotic, and the PCR was positive for Streptococcus pneumonia. So I think these panels are extremely useful in the situation in which somebody presents to you who has already received antibiotics.
Okay, thank you very much. And we have another question regarding the latency of herpes viruses. So as you know, these viruses can establish latency and can be reactivated in the case of infection. If you detect one of these viruses in the CSF with the ME panel, but the CSF parameters seem normal, how do you decide whether it's an infection or just a latent reactivation?
Yeah, it's a difficult question, but most of the times I don't have to I don't face that issue, because most of the times, if almost always, I get for the real concerning viruses, for herpes simplex viruses 1 and 2, varicella zoster virus CMV, I almost always have abnormalities on the spinal fluid and clinical findings. So it will be very uncommon for me to be faced with a situation of a completely normal. The only ones is, for example, the most common one, the human herpes virus 6. But from a clinical point of view, then, if I have normal spinal fluid, positive human herpes virus 6, I'm not going to treat. There's nothing going to do for them in an immunocompetent child. And, I think it's possible that I were to take human herpes virus 6 from somebody who has systemic human herpes virus 6 infection, exanthema subitum. And then we detect the PCR there. But for the other issues that you're asking me, for example, I never find a human herpes, a herpes virus in somebody who has a normal fluid. That has never happened yet to me.
Okay, well, anyway, we do recommend that all the results of the BioFire ME panel are interpreted in conjunction with other clinical and laboratory results, because we know, and there have been publications of some cases where, some of these herpes viruses are detected, but actually it's only a latent reactivation. So I think the whole history of the patient needs to be taken into account.
Right. And of course, if there is reactivation, then you still are in the same situation that you need to treat the patient. So if you have somebody with reactivation with pleocytosis and symptoms, then you'll also need to treat.
Thank you. We have another question. Do you have a different algorithm for testing immunocompromised patients? And is this based on CSF parameters or other clinical factors?
Yeah, the immunocompromised child and adolescent is always more challenging. So for that patient, this panel will be part of the workup for the concern of meningoencephalitis. Because first of all, one possibility in those patients with leukemia is that the presence of malignant cells in the spinal fluid. And then depending on how the immunocompromise is, we will also look for the possibility of fungal pathogens besides Cryptococcus. Of course, we can detect Cryptococcus, but for other fungal pathogens, we'll send a specific culture for that. We'll also do blood tests, look for aspergillogalactomannan, look for 3-beta-D-glucan and some other markers. And also we'll send in some of those patients the cultures and the PCR for mycobacteria.
Thank you. And one maybe last question. How confident are you to rule out other pathogens when you have a positive result for a viral meningitis with DME panel, for example, enterovirus, paracovirus, or other of the?
Well, I can tell you, yeah, I understand the question. I feel very, very confident, extremely confident, and I think all the publication will support this. Because in the other part is we still do the cultures, and I have never run into a situation in which somebody with a positive enterovirus or pericovirus has a positive bacterial culture. So we still do the cultures, but I haven't run into a situation in which somebody with an enterovirus is going to have a positive later on a positive bacterial culture. Everything has to make sense clinically, of course. There can be an exception. I'm sure there had to be somewhere out there in the literature, there may be, some example. But, when everything makes sense, you're in the right season, the right type of spinal fluid, the correct type of pleocytosis, with the parameter of glucose and protein that makes sense, and then you have an enterovirus, you have a great confidence that that's what is causing the illness on the patient. And again, I can emphasize to you, in my 5 years of experience, I haven't yet seen a situation in which I get a positive virus in the panel and then later on the culture comes back with a positive bacteria.
Okay, thank you very much for your time today, Dr. Fergie. And I'm sure that all of our attendees really learned a lot from your presentation. And it's great to hear from such an experienced user as yourself.
And thank you very much for the invitation to speak. And it's indeed a great pleasure and honor to talk to so many of my colleagues throughout the world. So thank you all very much and have a good day.
Thank you and goodbye.